Yes, there we go. All right, let me try that again. Good evening, everyone. Please accept my warm welcome to tonight's installment of our Dean's Lecture Series, Changing the Conversation. Whether this is your first time joining us or you are a return guest, I'm grateful to you for taking the time to participate in an event that aims to expand our individual and collective perspective and to get us thinking about the ways in which we can open and sustain dialogues, exercise our voices, and contribute to meaningful change in the communities we live in, learn in, and work in, for, and with. This past year has found our nation grappling with how to effectively confront and dismantle long-standing systemic racism. Sadly, we come together tonight in the shadow of yet another killing of an armed Black man, Dante Wright, shot by police in suburban Minneapolis. And we come together in the midst of the trial for the officer charged in the murder of George Floyd, with its shattering insights into the grief and the guilt that those who served as witnesses carry. As a college, we are part of the effort to document the multifaceted ways in which injustice and inequity hurt individuals, groups, and indeed hold us all back as a broader collective. We're also actively engaged in searching for effective, inclusive, and sustainable paths forward. The enormity of the problem may seem daunting, it may be daunting, but it can be undone. That requires going beyond appealing only to individuals to change their mindset, as important as that is, to re-engineering the social machinery produced by racism. Systems and structures that predictably and unfairly distribute education, jobs, housing, wealth, a host of exposures, and of course, ultimately health outcomes. Today's featured speaker and the incredible group of public health leaders who will join our conversation bring rich experiences from which we can learn and grow and begin to direct our efforts. Dr. Mary T. Bassett has dedicated her career to advancing health equity. She is currently the director of the FXB Center for Health and Human Rights at Harvard University and the FXB Professor of the Practice of Health and Human Rights at the Harvard T.H. Chan School of Public Health. Prior to joining the FXB Center, along with being a colleague at Columbia University's Mailman School of Public Health, she served as New York City's Commissioner of Health from 2014 to 2018. After a presentation from Dr. Bassett exploring what can be done about racism's role in health inequities, we will welcome 4 public health leaders with experience translating ideas into action at the county, city, and state levels. I'm going to go ahead and introduce our panelists now. and then that way we can launch straight into the discussion afterwards. Alex Jones, President of the Ohio Public Health Association and Assistant Franklin County Health Commissioner. Dr. Teresa Long, former Columbus Health Commissioner and College of Public Health Special Advisor on Community Engagement and Partnership. Stephanie McCloud, Director of the Ohio Department of Health, and Dr. Mysheika Roberts, Columbus Health Commissioner. Now, one final bit of housekeeping before we begin. Tonight's event will not include an audience Q&A to ensure plenty of time for our panelists to have a discussion. It will be recorded, and anyone who is not able to join or anyone who would like to revisit the conversation and share your questions at a later time can certainly do so. So now please join me in welcoming Dr. Mary Bassett, who in addition to her vast expertise has a very special connection to Ohio State. So Mary, if you wouldn't mind by starting by sharing that connection, because it really is what brought you here at a very busy time in your life.
Well, probably not as busy as people who are members of the health department. So my thanks to them also for coming this evening. And thank you, Dean Fairchild, for those kind and really thoughtful words. Yes, I was born in Columbus, Ohio. And I was here because my father, Emmett W. Bassett, was getting a PhD in dairy technology, which it turns out is really pretty much the same as getting a degree in biochemistry or medical or microbiology. And he, at the time, was one of a handful of Black PhDs in the basic sciences. And he had been seeking a doctoral program and had failed to get entrance. I probably would have been born in Europe because my parents were thinking of going there, but instead I was born in Columbus. He would have been 100 years old this year. So when Dean Fairchild contacted me, in addition, as you'll see, to having an affection for historians, I also really thought it would be great to have a chance to talk to people who are working in Columbus and to talk with you about a subject that we're all thinking about. And let me share my screen. I'm always a little nervous about whether this will work or not. Is it working? So I'm going to really try and do a couple of things. I'm not going to show you much data on the occurrence of health disparities. If anything has laid these bare, it's certainly been the COVID pandemic. But I'll show you a little bit. And then I'm going to make the case to you that in order to understand where we are now, we have to look backwards and look back to the origins of the racial hierarchy in the United States. And then we can start talking about how things have gone forward, how we can go forward. I think often that we sort of, and pointing out these relative disparities, we can lose sight of the fact that that there have really been great improvements in health. The 20th century saw greater improvements in health than have been seen in any other century. And this graph, though, shows what often has happened, that although the slope for infant mortality, which arguably is one of the most important public health measures, reflecting the overall well-being of a society. Although it's gone down for everyone, this line here is African Americans. In fact, it's gone down more rapidly and steeply for the white population, with the result that the relative ratio for a child's risk of dying in its first year has gone up. So that now here in the 2000s, Black babies were over 2 times, were sometimes over 2.5 times more likely, while it had been lower in the past. So the relative can shift even as the overall rates are going down. And of course, as I've already said, COVID-19 has really laid this bare with Black, Latinx, and Indigenous people more likely to get infected, more likely to be hospitalized, and more likely to die of COVID-19. And these disparities have not been small. They have been ranged between 2 to 3-fold higher and have achieved extremely high relative differences in young to middle-aged adults. Among Black men between the ages of 35 and 44, for example, the risk of dying is 9-fold higher than it was was for white men in that age group in 2020. And of course, these disparities have carried over into the likelihood of getting vaccinated, so that whites are more likely to be vaccinated, even though they're less likely to have become sick or been hospitalized or died of COVID-19. So these really reflect the impact not of many personal choices, but of the enduring effect of the racial hierarchy. And of course, as Dean Fairchild has mentioned, in May, we had the death of George Floyd. His death joined a long litany of unarmed, particularly Black men, but also boys, also women who have died at the hands of police. The U.S. kills more people the U.S. police kill more people than any other wealthy country, and disproportionately kills people of color, particularly African Americans, who have a 2.5-fold higher risk of dying as a result of a police encounter, even though they are less likely than whites to be armed. So also this disparity in excessive policing spills into the criminal justice system, where I know you're all very familiar with the disparate incarceration rates. So I like this slide because it shows us the arc of history that we must pay attention to, and the color coding used by the artist. This is an artist in Baltimore, Maryland, shows you how little of the history of Blacks in the United States has been in the green zone. Out of all this history, we have this much, and this is dating to the Brown versus Board of Education decision. Some people would say we should date it to 1965, when with the Civil Rights Act, the Voting Rights Act, and so on. And this is, of course, a very long history. The first unfree Africans, people who were not immigrants, they had been taken from Africa to sell as slaves, arrived in Jamestown in 1619. So 2019 represented 400 years. And the transatlantic slave trade, which brought millions of Africans out of Africa, went on for more than 2 centuries. I really can recommend to everyone that you take a look at this atlas of the transatlantic slave trade from which this map is drawn. You can see that most Africans came, this is Angola, where most African Americans are descended from people who were taken from Angola. But you can see that the US had really just a tiny share, although people moved from Brazil and the Caribbean to the US. The bulk of enslaved Africans were taken straight to Brazil, and about 12.5 million people were taken out of Africa. About 10.7 million died, so the crossing was very costly in lives, and out of that, just under 400,000 came. That's because I live in Boston. Boston, I think, doesn't realize that enslaved people arrived there, but they did. And the criminalization of Blackness, though, didn't end with the Civil War. After a brief period, the Reconstruction period, which ended in 1877, we continued to have in place by government, this is not just personal views, laws that put Blacks in the position that they were deprived of full citizenship. And this has really continued into the present day, where, as we've been talking about, the disproportionate use of police surveillance, the advent of mass incarceration, to which the drug wars contributed a great deal, and the impact of police-involved killings, which means that for Black men, these count among the top 10 causes of death. So this is our history. It's not one that I was taught in school, at least, and it's one that all of us, I think, need to pay more attention to. I'm often asked, how do you define racism? And there are many much longer definitions than this one. But this one works for me because it includes the notion of power. You need not only the belief that people of African descent are inferior to people who hail from Europe, you need the power to do something about it. And that's why this one phrase, I think, really captures the idea that racism is a system, that it's based on power, often the institution of state power, and that it also is embedded in our many institutions, including our legal system or our educational system. It's reflected in our policies and practices, in our culture, and it extends back over a very long history. So I'm going to turn now to talk explicitly about the idea of structural racism, which amazingly is really widely spoken about. I remember as health commissioner, I wrote a piece in the New England Journal using the word racism, and I thought that was pretty brave. But we now have a president who has used in his inaugural address, used the phrase systemic racism and talked about white supremacy. But in this framework, structural racism is sort of the platform on which various forms of racism exist and are replicated. And I'm going to go through all of these. I think of them as occurring before what we in public health often refer to as the social determinants of health. These are the things outside of direct personal health care that can affect our health, where we live, what kind of education we have, what kind of job we have, our income, the safety of our neighborhood, and so on. All of these are pathways through which inequalities in health are mediated, and all of them are filtered through the effects of structural racism, which mean that people of color, if we talk about a gradient, are on the bottom in terms of access to jobs, high quality housing, high quality healthcare. So let me go through these now. And the first one is internalized racism. And I have to say, we don't talk that much about these. Probably the most poignant example is the Stahl experiment, which was used by Mamie and Kenneth Clark and actually cited in the Brown versus Board of Education appeal to the Supreme Court. This is a form of racism that occurs within individuals. I'm talking about it as how it makes people of color feel that they are inferior, but it also can help people who are classified as white in our society to just feel superior. It includes the ideas of implicit bias. And in this experiment, this little boy is being asked to choose which doll he likes the better, the white doll or the black doll. And the majority of Black children who were very young, 4 or 5 years old, picked the white doll as the good doll. And this was repeated by a high school student in the 1990s, and the exact same thing was found. We really spend most of our time when we talk about racism talking about interpersonal racism. And these are the things that occur between people. They can be explicit. They often are explicit. And they often are implicit or unintentional. When you live in a society that has a racial hierarchy, we all absorb those things. And it may affect the way in which we behave. This is distinct from institutional racism, which occurs without the decision of an individual. or actually their individual action. This is a picture of a little girl in New Orleans. I always notice her white ankle socks. I can't help it. Ruby was only 5 or 6 years old when she was escorted into an elementary school in New Orleans, and riots followed for 3 days. And this is because the school system, whatever the teachers thought or whatever the parents thought, simply did not accept Black children. So this was an institutional decision that was independent. It reflected racist thinking, but it was independent of individual decisions. And finally, I'm going to just read out this rather long definition that I and colleagues proposed. Structural racism is sort of, as I've said, the platform on which all of this lies. It involves interconnected institutions whose linkages are historically rooted, culturally reinforced. It refers to the totality of ways in which societies foster discrimination through mutually reinforcing and equitable systems, which in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect adverse health outcomes. So it's important. We worry about this in public health because it affects our health. And when we talk about how to correct the patterns of unequal health outcomes, we have to go beyond the idea that this is simply related to individual prejudice or individual behavior. We had, when I was at the health department before he became quite as famous as he is now, Ibram Kendi came to speak. He's written a book called How to Be an Anti-Racist. It's a bestseller, which is also a sign of our times. And he said while he visited with us that he uses this as a litmus test. And I keep coming back to it because I think it's really useful. He says, when you think about an explanation for racial inequities, do you locate the problem in the people? Or are you thinking about the context in which people live? And if you locate the problem in the people, you should interrogate it as a racist idea. And that doesn't mean that it is, but it means that we should be really careful about all explanations that say that the problem lies with the people who are experiencing the excess adverse health outcome. And these are all the many ways in which racism tracks to health. People of color have lower incomes, far less wealth, the balance of assets and debts, are more likely to work in risky occupations, experience trauma, which we've seen on display in if you can bear to watch the trial that's now going on. And of course, there's differential marketing of unhealthy products. At the health department, we found that in poor neighborhoods, the presence of alcohol, sugary beverages, and high-calorie foods marketing was far higher than in non-minority neighborhoods. And we're talking now about voting rights, for example. And of course, there are, and we need to acknowledge this, maladaptive behaviors. And if we get a chance, I'll talk with you about stereotype threat. I'm worried about time. Maybe somebody should signal me I'm not watching. I'm racing through, in fact, to make sure that we have time to talk.
Just a few more minutes we have.
Yeah, so I use redlining as an example of that brings together all these ideas of structural racism. It's based on government action, these literally redline maps, that's Columbus, and that led to the behavior of private banking. It didn't matter if the banker liked Black people or not. A person who lived in a redline neighborhood weren't going to get loans. It affected private developers. It permitted the use of things like restrictive covenants. And it was very widespread in the United States, over 200 cities. And of course, owning a house is a way that money is transferred from one generation to another. These have been digitized, allowing a lot more public health research to look at the impact of redlining. And I don't know Columbus. This is a digitized version of the Columbus map. I gather gentrification has often offset the impact of redlining, but it leads to displacement. But one thing that I read from the Community Reinvestment Coalition suggested that many of the neighborhoods classified as hazardous and therefore not loan worthy, mortgage worthy, are still low to moderate income neighborhoods, and the so-called best neighborhoods are still mainly white. And of course, in New York City, which is a highly segregated city, the redlined areas continue to track with the poorest neighborhoods in New York City. So, how do we use this framework? Well, one is that I think we apply it to when we think about what's driving these racial disparities. We identify the Black-white wealth gap, which is talked about much more than it ever was, and has triggered a conversation about reparations, which is now no longer considered quite a fringe issue, even though the majority of Americans don't agree with it. It focuses our attention on the policing and legal system, on the structural factors that affect healthcare access. And then, of course, we need to think within universities, who are students there, who are faculty there, and how does this affect our whole project, our whole intellectual project. We have to look at our instructional programs and whether we're thinking and teaching about racism. And of course, public health as a whole has been hugely underfunded. So that tackling these issues and requires more funding. And I hope that the COVID pandemic has really laid that bare. I think perhaps I should wrap up and just show you once again the kind of taxonomy that I think is useful to keep in mind, and remind us of Ibram Kendi's call to not blame the people who are experiencing the adverse outcomes, but ask ourselves, what are the range of choices that are available to people who are experiencing these racially disparate outcomes. And with that, let me stop sharing my slides and thank you.
Thank you very much. I'm going to open. I'm going to throw out a question for you to first answer, Dr. Bassett, before I then turn it over to each of our panelists. And of course, you can weigh in on the question I asked too, but I encourage you to either ask your own questions or to reflect on anything that Dr. Bassett talked about that particularly resonated with you and your experience, and use your own experience to illuminate that. But I would simply underscore that it's so important. I don't say this just because I'm a historian, but starting with history really matters. I think one of the challenges in public health is that we're often using data that underscores disparities, and we don't always drill down into it in the way we should. And whether that's because we assume that the data speak for itself, because we share an understanding of the kinds of structures that create these gross disparities. So what advice do you have to public health to be more persuasive, to avoid that tendency to let's just show the disparities, but to take the time to tell us where and how they arise, but also what's the role, in particular of academic public health, in steering us towards some of the structural solutions. And I noted, and I can't remember if you said it in your talk or in the discussion we were having before, you're about the limits of appealing to behavior. So how do we both unpack the data that we have and that we have a command of in a way that points us towards structure and away from behavior that points us towards structure and away from, as Kitty puts it, problems that are located in people, either in their choices or in their genes.
Right. And I'm glad you mentioned genes, because I probably should have said that. I sort of keep hoping that we'll be past that idea that people of African descent are genetically different than people of European descent. But even with COVID, somebody came up with some idea of nasal receptors that Black people have and might explain why they're getting COVID. It was published in a well-respected journal. But it's really important, I think, to be extremely skeptical, as the reviewers of that article should have been. And, there are a couple of parts to this. One of this is these are big societal issues, which we obviously can't solve alone within public health, but that doesn't mean we should be silent about them. We should, you can raise problems that you can't solve. I can say that more freely now that I no longer work in government, frankly. But additionally, I think it's really important to be disciplined in how we talk about racial disparities. They're so long-standing in this country that they seem practically normal. I don't think anybody was shocked that the COVID-19 pandemic has, tracked along these inequalities, but they're not normal. And we need to just not put them out there and, just say they're disparities again. We need to try and think about why they exist. And we need to really be very strict about not reverting sort of reflexively to the ideas of people are ignorant, people make bad choices, or people have bad genes. We need to talk about what people's opportunities for healthy choices are. And that's why I think it's really important when health departments start thinking about how they can use the tools of government to change that. That's what was done with tobacco control, right? We didn't just implore people to not buy that pack of cigarettes. We raised the taxes. We limited where people could smoke, and took structural action in what's been a fairly successful campaign. And I think that health departments still have that within their purview. But I would much rather hear from my colleagues in health departments. And since I'm out of the fray, I know that these things aren't easy, and that structural changes and structural instruments, policy, regulation, all are things that are contested politically. Bloomberg, a billionaire mayor, was told by his team not to talk about banning tobacco use in bars and restaurants because he would lose the mayoralty. And he, decided to go ahead with it. And of course, he's famous for his public health work.
And of course, that's an area where Dr. Roberts has some expertise and experience too. So I'm going to open the floor up to you, Dr. Roberts, to either comment on things you've heard, bring your own experiences to the table, ask a question.
Sure. Well, thank you. And thank you so much, Dr. Bassett. Great presentation. And I appreciate you taking the time with us this evening. What really struck me is the comment you made by Kindy about don't blame the people. And in context to where we are right now with this pandemic and knowing that Black and Brown individuals have been disproportionately affected, and you acknowledged on one of your slides, they're also, I wouldn't say they're the least likely to get vaccinated, but we know there are challenges to get them vaccinated. And I think when we often blame the people, someone, it could be public health or someone else, sets up a clinic in a predominantly Black neighborhood for COVID-19 vaccine, and they're disappointed that no one showed up. And they blame the people. They say, well, they didn't show up. And what I've asked my team and myself, what did we do to get them to show up? Right. And what I've reminded everyone is we have to work probably twice as hard to get the Black and Brown people to the door to get vaccinated. We've got to provide them with education. We've got to dispel the myths. And then we've got to make sure that it's accessible wherever we're going to vaccinate them. It's accessible and it's a place that they feel comfortable in. You know, trying to get them to come to the Ivory White Towers is not going to be a location that's comfortable for them, whether there's a transportation issue or not. If they don't feel welcomed in that environment, they will not come. But I think many of us, and hopefully not those of us in public health today, but we have this, you know, we're distracted by the fact, well, they didn't show up. Right. And we blame them versus, well, what did we do to help them show up? So I really appreciate that. And that really resonates with me. So thank you.
Thank you. Thank you, Dr. Roberts. Dr. McCloud, I'm going to open up the floor to you next. And you're the newest in the crew here, yes. even newer than I am in your role.
Yes, thank you. It is it's new to the role, and boy, it's been a whirlwind coming into this role. So thank you so much for having me here to join you this evening. Thank you both. That was a fantastic presentation, Dr. Bassett. Thank you. It is. What's interesting that we see these things, we hear these things, and, you know, from our point of view is you just can't revisit them enough in some ways. So it's important to revisit as we make it part of the fabric, to your point that many times we are now things that previously wouldn't have been acceptable to discuss, to talk about now are in fact acceptable and easier to share and to discuss with people. But also from a standpoint of when the governor put out the Minority Health Task Force and we issued the report last year, we were all on a call discussing the task force report and, you know, talking about it was very well done, it was very helpful. And one of my first comments was, it is very helpful, it is very good, and it's also very useful to know that most of this could have been written in 1960. You know, meaning that, you know,
no, it's not funny. I'm sorry.
Yeah, no, but while many things are, we've made, you know, while progress continues to be made, unfortunately at a snail's pace, sometimes we need to revisit these same conversations over and over so that we can talk about what we need to do, what we've done, what we need to do, what we need to do differently. The fact that so many of these things are in fact still part of the fabric, and changing that fabric and changing, as I've said, both with my team at Health, and many of you know I came from the department, came from the Bureau of Workers' Compensation, is this will be not about, you know, changing policies and doing this, and that's all part of it, but that the end goal is to change hearts. To change hearts if you want it to be part of the fabric. And as we change hearts, now you have people who stand with you, who understand, and now they're out there with you working to change other hearts, because there's no doubt the task is daunting. And it's daunting, especially, as I said, when you look at a task force report in 2020 and say, look, you know, some of this could have been written in 1960 and was written in 1960. So working towards some of those, what do we need to do different? Where have we made progress? Where can we build on that? Back to the points raised earlier, of course, COVID shown the light in a very, very stark way that I think, both to the points you made earlier, everyone knew, but weren't really talking about. And when you have a once in a lifetime, hopefully, I'm knocking on my desk here, when you have a once in a lifetime global pandemic that shines the light in this manner, you have to take advantage of that, because, you know, I think taking advantage of people understanding now, before, when COVID's over, before they move on to the next big topic that may draw attention away, we want to use this time to talk about the things that we need to do, the investments we need to make, both in terms of people and financial and political investments that we need to make for lasting change. Last year, after the murder of George Floyd, when I was at the Bureau of Workers' Comp, we did several things at the department and opened up a forum. I called it well, my initial name for it was The Conversation's Not Over. We changed it to The Conversation Continues, and it was an ongoing forum where people could come on and talk. It sparked some moderated discussions and forums with our senior team, and then asking them to take that down to their senior team. We have a what we call a disability evaluation panel at Workers' Comp that are outside physicians that help us review certain cases. As a result of that, we now put everyone through yearly implicit bias training.
Good.
So taking advantage of those opportunities to make permanent change out of what sometimes appears as windows, but using those windows to step through and hopefully engage in some permanent change. The learning more about our efforts in vaccination, it has been hefty, and Dr. Roberts is exactly right. We are trying to do more in the education space prior to sending people out, because for some people it's availability, but when you have vaccine hesitancy, it's not hesitancy because it's 3 blocks away instead of 1 block. The hesitancy is a result of much more, as we know, and being able to answer those questions.
Right.
The other thing that I worry we don't do enough of in the health space is telling people it's okay to have questions. I feel like a lot of times it's just like, oh, the vaccine or whatever it is, it's great, you should do it. You know, people have questions and it's legitimate questions. And it's very important to make them comfortable with the idea that you are allowed to have questions and you're entitled to answers to those questions before you undertake something that you have some hesitancy about. So I won't hug the whole.
And I think that's so important that people have valid concerns.
Yes,
and that they, you know, that they deserve, and they have reasons to be distrusting, because institutions have been untrustworthy.
Yes,
and that this isn't only about Tuskegee. This is about people's experience in their healthcare, where they haven't had the kind of respectful, dignified care that everyone deserves. So I think that's great. Taking the stance, but it's great also if you've overcome the accessibility issues. I really think that they were kind of minimized when at the beginning. I don't know anything about Ohio except that I was born there, but you know, in Massachusetts, it was all web-based. There was not even a phone line, nothing. There was no place you could call to get an appointment. That's all been changed, but it really was in response to complaints. So if you didn't have internet access, if you didn't have a job where you could drop everything and go to your appointment, if you couldn't manage to stay online for like 8 hours, trying again and again, which is what my sister did, to get my mother an appointment, you know, etc.
We did share some of those struggles early on as we tried to pinch out quickly. We spent a lot of time trying to ensure there were a lot of providers, and literally, especially in some of our high SDI counties, first our 7 largest urban counties, as well as some of our rural counties in Appalachia, going through literally county by county in a heat map and looking at providers and making sure we had a number of providers. And the more providers you have, it does complicated. I mean, Dr. Roberts will tell you there's opportunity for complication, but we have right now 1,400 providers and growing. That means I did the math on this the other day, but I think it's about 9,000 Ohioans per provider. There's other states in Illinois, it's 15,000 provider. It's 15,000 residents per provider. They have more people, but when we have 1,400, they have like 833 providers. So we've done quite a few things in addition to mobile mass vax. We've done some, we've also participated in some webinars and some roundtables, but obviously as we move through this, what we continue to learn, one thing we've said is I won't be married to a mistake just because it's mine. And if we're not doing enough of what we should be, then, you know, let's learn from that. And so we're having those discussions, putting together a health equity team, and we have a health equity team for COVID, but also expanding just in general, because there'll be a post-COVID world. And again, if we don't take what we learned here and extrapolate that out in the places that it needs to, especially in some of the places that just turn your stomach, infant mortality and maternal mortality and child, it's just, we have to extrapolate those out.
Let me shift. Thank you so much. I'm going to shift our focus now to the county and ask Assistant Commissioner Jones to weigh in, to either join this conversation or start a new conversational thread from your vantage point.
Great. Thank you so much, Dean, and thank you so much for the invitation. It's great to be here. And thank you so much for your presentation, Dr. Bassett. You know, I think reflecting on the past is key and first and foremost. And, you know, with it being April being Minority Health Month, and as well as a person of color sitting on this panel, it really speaks to me. And so I just want to say thank you for that. And thank you for this opportunity. You know, Tuskegee is only one component. And I think, you know, there's a longer history with our healthcare system that, you know, us in public health, we are not unscathed from. So we need to acknowledge that and keep that in mind as we continue our daily work. So I actually wanted to ask you a question. So I have the privilege to represent the Ohio Public Health Association as the president this year, also in my role at Franklin County Public Health, and my colleagues across the state. Many of us have declared racism as a public health crisis here in our communities. In the state, there's the time is now. If there's ever a time to do it where we might have traction and momentum, the time is now. So, you know, as we are working through our declarations and putting, you know, pen to paper and action steps and not just having them be words, you know, we are all doing many internal processes and activities, external as well. But I'm curious to hear if you've seen any perhaps best practices, any things that might have been not missing, but maybe not looked at, some things for us to consider as we continue down this racism as a public health crisis journey in our communities.
Right. I was talking to somebody at the law school here that says I've identified 178 of these declarations. And of course, there's now one more to add to that list. The federal government's Centers for Disease Control has added its voice to the call that racism is a public health crisis. And I think words matter. And it's and these declarations are important, but as you say, what's really important is how it affects what we do. And I think of it as having two wings. One is the internal process, and I think Dr. McCloud, you've raised, you know, you've talked about an internal process where people educate themselves, where people get training in not only an implicit bias, I would argue, but also in the history of the United States. I saw some questions in the chat around reparations. Maybe we'll get to that, or maybe we won't. So I think that that's what I did at the New York City Health Department. And we put the requirement for this into our civil service codes. And I hope that means that, in other words, it was part of people's annual evaluation that they'd had, that they'd participated in training. And there was also a requirement for participation in emergency preparedness. So I hope that sort of institutionalized it beyond the individual commissioner who is there. And then I turned to every unit, not just the programmatic ones, but budget, recruitment, and said, bring a racial equity lens to your work. And I helped support it. Not every place has the kind of budget the New York City Health Department has. And I was able to, without getting new money, find money to support this. And I was really surprised at how, you know, the leadership can't figure out everything. I think that the key here is sort of challenging people to rise to the occasion of asking what they can do to contribute to mitigating the impact of racism. And I'd be delighted to, but I still feel that Dr. Roberts should say something. You already spoken. Dr. Long or Dr. Jones, do you want to add more in response to what I said? But I think it's both an internal challenge and an external challenge. We need to look at both our programming in public health and also at who we are, what we look like, how we handle problems.
Oh, thank you so much.
So
I appreciate that.
So, Assistant Commissioner Jones, do you want to add anything? Or should I hand?
I think that's a great segue for Dr. Long. So
all right.
So
So Teresa, Dr. Long, you kind of bookend us. Mary is an insider, outsider, somebody who was in a public office and now in academia. You're in that same role. So what are your reflections, questions, thoughts, provocations how would you add to this conversation? And how would you, and unmute yourself.
There is a rookie mistake. Thank you, Dean Fairchild. And thanks, Dr. Bassett, so much for a very eloquent talk, a critical message, really, I think, at both a super challenging time and a pivotal time, I think, in public health and really in our country. I think we all need to hear this, and I think in public health we are increasingly hear it, but we also need to learn how to share it better. And so I think we've been hearing some about that. And some of that's sharing it and communicating better. Sometimes it's showing up and standing up and speaking up, and we can talk more about that. I also, my esteemed panelists, so Dr. Roberts, Director McCloud, Commissioner Jones, thank you for your reflections, because you're right there and you're on the front lines of COVID, but you've been on the front lines in lots of different ways. So thank you for your leadership on these public health issues. I guess my reflection is that, again, it's a moment in time where we are, and our nation has been on a trajectory for 400 plus years. Many of us have started working on, and actually I'm proud, we had a place-based strategy starting very early in the 90s and grew it in the early 2000s, set up a Center for Health Equity, and yet all of this is not enough. Not making the differences, having the impact that we need to. And I think that what Dr. Roberts shared about both listening, but going to and sharing in different ways, having the practitioner look like the people being served. I mean, all of these are critical components. And really, it's about re-engineering. And I think you said that early on, Dr. Bassett, about re-engineering systems that have unfairly advantaged people. So I think we're trying hard. I think across the country we're trying, but we really do need to change it up and think about different strategies. And I appreciate that you mentioned one, and I've seen some in the chat about a strategy that I'm curious about your thought. I'll tease it up a little bit, or tee it up a little bit, but tee it up a little bit. And that is the notion of reparations. And actually you wrote, as I was quickly learning more, you wrote a beautiful piece with actually one of your colleagues, a Boston colleague, Sandra Galea from BU, about reparations being a public health priority. And so for those of you who don't know, it was in the New England Journal, end of November, I think the 26th of 2020, really eloquently helps us think about just what Dr. Bassett presented, and yet how we do need to think further, and a little bit more detail about some of the challenges and the gaps that do exist. Yes, infant mortality we've talked about. Yes, health, life expectancy, but also wage differences that the collective wealth of African-American families has been shown to be $10 for every $100 of white families. And again, some of these are very long-standing gaps. And that unless we start to think about those kinds of gaps that really have to do with the institutions and the structures of power and wealth, and access to resources, that we may not be successful in really addressing the health issues and see some of these gaps and health disparities change. So for those who haven't read it, it's a very eloquent editorial. And I think speaks exactly to thinking about how maybe we don't talk about the social determinants, we talk about the conditions in which people live, and thinking about all of those and how could they be? So here's my question. How should we be thinking about reparations as a public health priority? And clearly it could be one of the ways And if it were one of the ways, how would you suggest that we move forward as public health practitioners, being again a part of an entire community in thinking about reparations?
Right. Well, first of all, you summarized the challenge pretty eloquently. So thank you for that. I think that the many people really consider reparations, and myself included, a kind of non-starter. This not that I disagreed with it, and I'll try and address some of the things that I saw in the chat, but that I just thought it would never be something that could be achieved. And this is the idea that people in the United States who are descended from people who were enslaved, brought here from Africa, and their descendants who labored for nearly 250 years without compensation, were then made free, but with no compensation or capacity to begin a new life as a person who wasn't enslaved, and then who faced the whole range of barriers to accumulation of wealth, ranging from pure terror in the South, where something like 4,000 or 5,000 people of African descent were lynched. These were extrajudicial killings that the government not only didn't interfere with, but sometimes participated in, to redlining, which I've mentioned, which deprived people of access to home ownership, made them vulnerable to predatory lending processes. All of these explain the wealth gap that we see today. It is not a problem of failure to work hard or to attempt to pursue education, and that's why it's important to talk about, because there are very clear links to income and health. That's been documented over and over again for well over a century, and probably dating back to the Industrial Revolution in England and so on. And there's much less data on wealth because it's much harder to collect. That's our assets minus our debts, than income. But there's no doubt that wealth gives people resilience. It makes them able to endure shocks, make plans for the future. Income is just the flow of money, but wealth is sort of the reserve, and it counts. And the wealth disparities in the United States are huge by race, as you've just said. In fact, a college-educated Black person can have less wealth than a high school dropout who's white. And that's because of the lack of intergenerational transfer of wealth. I think I'll be, still have a living parent, but in my family, I'll be the first to benefit from intergenerational transfer because there just wasn't anything. And, so wealth counts, and it counts for health. And these gaps are just too big to overcome without a concerted program. And they also, they are answerable, in my view, by the federal government, because these were not just the accumulation of private prejudices. It was the result of state policies, policies enacted, protected, and promulgated by our national government. Somebody asked, well, my parents, I'm not, I'm not of that origin. My parents didn't own, or my ancestors didn't own slaves. But the fact is that all of white America, all of this country actually benefited from an initial economic setup which relied on enslaved labor. There was a reason that the United States rose so rapidly into the ranks of wealthy nations. And part of it was the extraction of that wealth. And not just the South, also the North, which was the finance engine. I could go on and on, but the fact is that you didn't have to be personally involved. That's what structures mean. Everybody who lived in a society where whites had rights that Blacks did not, who was classified as white, experienced benefits and still does. The Capitol was built with enslaved labor. Where our lawmakers go are benefiting from a building that that, is there to this day, to give you an idea of what structure means, that so that the structures persist, the benefits for them have been distributed unequally. And that's why you can have, the people contending for the Democratic presidential nomination actually beginning to talk about reparations as an idea. I realize that it's a radical idea, but I think that we are witnessing that we're not going to get away from this until we sort of grasp these divides with both hands and agree that we need a concerted action, that the very good work that you've done, Dr. Long, that was being done in New York City, which also adopted place-based strategies, just aren't of the scope, the magnitude, and the heft that we need to overcome racial disparities in health. So with that, I think we've made it over to you. I rambled on for the full hour. I want to thank the panelists for the chance to talk with all of you, and you, Dr. Fairchild, for inviting me.
Oh, well, thank you. Thank you so much. Thanks to all of you. And the purpose of these conversations is not to steer clear of the radical, not to steer clear of what's clearly politically charged. I want to thank Dr. James for sharing the poem he wrote about reparations in the chat. And I would underscore one of the really great books to read on this is a book called Empire of Cotton. And it underscores the points that Mary was making, that slavery was part of the rise of the industrial Northeast. When the Civil War disrupted systems of slavery in the South, that empire moved to other countries that also relied on something very close to forced labor. It was something we all benefited from. It's implicated in all of our systems, not just those who enslaved people. So I would encourage you to go to Empire of Cotton. I would thank all of you for participating in this conversation. It's a conversation we have to stay in together as leaders, as scholars, as a community. And when it gets tough, we can't back away from it, but we have to engage with these radical ideas, and we have to think about what are the bold solutions that we need to press forward so that 100 years from now, in 2000, won't even be 100 years, in 2060, we're not looking back at 1960 and saying we're writing the same things again and again and again. So I hope we have this conversation in a moment, a watershed moment, a galvanizing moment. And I thank all of you all for being part of this conversation.